This is part 2 of our 4-part series on how to interpret knee X-rays. In part 1 we looked at the knee X-ray from the front, which is called the AP view, and in this part we're going to look at the knee X-rays from the side, which is called the lateral view. To obtain a lateral view, which is quite demanding to get it exactly right, the patient is placed on the radiology table with the knee bent to 30 degrees and the X-ray plate underneath the knee on the lateral or outer side. In this position you get a very nice view, particularly of the patella, but also of the femur, the tibia and the fibula. We're going to flip this X-ray up so that you can appreciate it better. This is the more normal orientation that one is used to seeing. Here is the patella or kneecap, the femur or thigh bone, the fibula, the little bone at the side of the shin, and the tibia or shin bone. You can see a number of bony contact areas quite clearly in this view. Between the patella and the femur, the contact area is called the patellofemoral joint. Between the femur and the tibia is the tibiofemoral joint, and between the tibia and the fibula is the tibiofibular joint. From this lateral view one can appreciate a number of things. There are none on this particular X-ray, but one would be able to see arthritic changes with bone spurs and cysts on the joint edges. One would be able to see bone breaks, particularly of the patella and the back of the tibia, which may not be so evident in the AP view. However, unfortunately, it's quite a technically demanding view, and is often ill-performed, and potentially valuable information left unappreciated. The patient needs to be lined up very carefully, so that on the film all three of the joints already mentioned should be clearly visible. The knee should not be bent more than 30 degrees. The femur should be positioned so that the two rounded ends or condyles of the femur appear as if there's only one, because the one condyle is overlapping the other in the view. So let's have a look at this view in a bit more detail and see what we can deduce. You can see in this particular picture a very vague outline of the skin and muscles, but you can't really tell anything useful about them. Sometimes one can deduce a little bit, but it's really not of any great value. MRI scan is much better. Again, here you can see the quadriceps tendon and the patella tendon above and below the patella, but only very faintly, although some information could be gleaned if a tendon had ruptured or avulsed off the bone, or if there was stress at the bony attachment to the tibial tubercle, which I am marking with a circle, such as in Osgood-Schlatter's disorder. One can get quite a lot of information about the height of the patella. Sometimes the patella is positioned too high or too low, which can lead to further problems in the knee. There are a number of ways that we can assess this. In one technique, the surgeon will look at the area of contact of the patella with the femur and compare this to the height of the patella above the flat surface of the tibia. The result is expressed as a ratio, and in this patient the patella appears to be slightly higher than normal. Another way of measuring patella height is by using Blumensaat's line, a linear shadow on the X-ray which represents the inside roof or notch between the two rounded ends of the femur. Normally, if one extends this line, the patella would be sitting on it. Again, in this case, it's a bit higher than normal. Although they're not visible on the X-ray, one can make some inference about the presence or absence of the shock-absorbing menisci, because their presence accounts for some of the space between the femur and the tibia. An MRI scan would be much more useful, however. One can also make some inference about the cruciate ligaments, even though they too are not visible on the X-ray. A line from where the cruciate ligament usually attaches at the top of the notch and drawn through the spines of the tibia would normally extend parallel to the back of the tibia. If this relationship exists, as in this case, then the cruciate ligaments are probably intact, because a ligament rupture would allow the tibia to slip into an abnormal position. Again, one would prefer an MRI scan to assess the cruciate ligaments. It is clear by now that X-rays are all about interpretation. I won't go into this in any more detail. That's enough for you to absorb in one go. But the real message here is that it's not simply a matter of looking at the bones themselves, but their relationship to one another, the junctions between the bones, looking for abnormalities where soft tissues would come into contact with the bones, and making inferences, perhaps following through with another investigation which may be more costly. At least from an X-ray you can get some information very quickly, and in many cases the information you get is better than from other imaging techniques. So this is the end of this part of the series. Thank you for listening. Please look out for part 3 and remember to subscribe to our YouTube channel.